I am Dr. Sabrina Vismara. I work in Paris as a surgeon of cataract, and I will repeat a lot of the things that Dr. Alfat just said. So I'm sure you will understand at the end of this presentation. So the ESCRS R&D team prepared last year a very full classification for all the existing types of IOLs. And they decided that monofocal plus lenses should provide a normal vision up to 83 centimeters, while we can accept functional vision, let's say 0.3 logmar, at 62 centimeters. So what we can see on these slides is that according to ESCRS, the monofocal plus should provide a normal vision for intermediate distance, like computers, while an EDOF should also provide a functional vision for reading. So the question is it possible to obtain a functional vision at a near distance also with a monofocal plus lens? So what did they try to do with the only lens, as Dr. Alford said before, that has a solid literature is the IOLs from Johnson & Johnson. And the studies showed that with a mini monovision, we could target hemitropia in one eye and -1 diopter in the other one, and we could obtain a functional vision, also for reading. So IOLs, compared to a conventional monofocal IOL, improved intermediate and near visual acuity by 1 to 1.5 lines, which is interesting. It depends then on the testing, if it's a monocular or binocular. So the newer IOLs, as he showed you before, like Vivinex Impress, the Isopure from BVI, or Zoe Primus, and all the other new ones, they could offer similar outcomes to IOLs, but there are no comparative studies existing here until now. So the ESCRS decided that the future research on these new partial range of focus IOLs should confirm the findings and establish if the lens is superior to a monofocal and a non-inferiority to the IOLs. So let me tell you something about the Extend, even if you already heard it. I want to see and test if you understood everything. So we can see here a very interesting video from Hanita that speaks about the Bessel beam, which is the first Bessel optic monofocal plus IOL. And this was made with this extended Bessel optic technology. The Bessel beam are commonly generated with the axicons, which convert the incoming beam into a conical wave and whose angular components interfere constructively on the optical axis. And, oh, sorry about that. Sorry. I wanted to stop it so you could see really well what happens with the conical wave. And we can see that this produces an extended depth of focus, and the Bessel beams have a property of non-diffracting propagation. So this is very interesting, and that's why it is used for high-resolution imaging in ophthalmology and increased fixation targets. So Hanita integrated the axicon, or the half axicon, on the posterior surface of the IOL, and they preserve a spherical geometry on the anterior. So this provides patients with excellent intermediate vision, and alongside with a comparable to standard monofocal far vision. This with a 3 millimeter aperture, and when the pupil dilates in the evening, we have an aspheric surface optimization that directs maximum energy to the distance vision. So that's why the patients read fine details in dim light and still enjoy a good night vision. So about some details about the Extend, the power range until now is between 10 and 30 diopters with a 0.5 increments. The toric version is coming out very soon in October. The material is a hydrophobic acrylic, of course, glistening-free material with all the filters inside. The delivery system is both preloaded, non-preloaded, depending on the surgeon, what they prefer. I know in the US they all have a lot of help, so they don't need to have a preloaded, but usually in Europe we prefer that kind of assistance. The incision is inferior to 2.4, and I will show you on my video in the next slide that you can totally insert it in a 2.2 incision without breaking it or ruining it. So the optimal result of this lens should be hydrating the lens before. So it will open up very smoothly, as you can see on the video. So this is actually the first lens I implanted. So we can see that it's pretty easy, even the first time, and it opens up very well. You just need to hydrate it first. So before you start the surgery, put the lens inside your BSS, and so it will hydrate and open up very easily and smoothly. So as Dr. Aufhaut showed you before, these are his results actually. So we compared first on bench testing the Extend versus the IOLs, and it showed very close optical performances in the defocus curves that you can see here, and depending on the pupil dilation, also the far visual acuity and the disturbance are very low, as you can see down there, and very comparable to the J&J lens. On still an optical bench, we compared it to monofocal lenses. So the far vision is uncompromised. As you can see, it's very similar on both monofocal and extend. But we can see that there is a significant increase in depth of focus without compromising this far vision. So some clinical results from Dr. Bianchi from Argentina, who implanted 12 lenses and made a binocular defocus curve. And strangely, what we can see is that at 66 centimeters, they have 0.25 logmars. So there's a discrepancy comparing it to the bench testing we had, which is, it seems to be better in real life. So he compared also to the monofocal Acrisoft. You can see the defocus curve, that it's much worse, of course, in near vision. Dr. Sova from Ukraine implanted 21 eyes and made this monocular defocus curve. And even here, it seems better on the defocus curve, the vision, even the monocular vision, with a 0.35 logmar at 66 centimeters. Same results with Dr. Robin in France, who implanted 62 eyes and made this beautiful monocular defocus curve. The comparison, he also compared it with patients in which he implanted the IOLs, and we can see that the two curves overlap very well. So in conclusion, the benefits inferred from bench testing and the one reported by the surgeons, as we can see, far vision, acuity, and the disturbance levels are very similar to monofocal IOLs. And but in this case, we can obtain a very good functional intermediate vision. So I will leave you with one question and think about it. If the future of cataract surgery is moving beyond traditional monofocals toward monofocal plus lenses, would you consider to implant monofocal lenses anymore or not? Thank you very much.